Welcome back to the deep dive. Today we are shifting gears a little. We aren't just exploring a topic for general curiosity. We have a very, very specific mission. We are stepping into the shoes of an MD anesthesiology student. Specifically, let's say, someone preparing for the Gujarat University exams, who is staring down the barrel of a history of anesthesia paper.
That's exactly right. We're going to treat this as a high-yield kind of audio revision session. We've pulled out the big books, Miller, Morgan, Wiley's, and the goal is to synthesize all that historical data into a narrative that actually helps you answer the question, write a short note, or, a long answer on the history of anesthesia.
And it's not just about memorizing a bunch of dates, is it? I mean, looking at the source material, there's a real reason this topic keeps showing up. It can feel like trivia, but it's really the blueprint for safety.
It is the absolute foundation. Examiners love asking about the pioneers because testing your knowledge of them isn't just about history. It tests whether you understand the evolution of pharmacology, of safety protocols, of technique. When you understand that spinal anesthesia started with cocaine and massive, massive headaches, you expect that modern 25-gauge needle a whole lot more.
And looking at the past papers, you just can't avoid this topic. You get the big, long questions like trace the history of general anesthesia, but you also get those tricky short notes on specific people. William T.G. Morton, August Bier.
Oh, absolutely. Or the dreaded viva voce. You walk into the practical and the examiner just casually asks, so who gave the first spinal? Or what on earth is the letheon?
Yeah.
You need to have those answers loaded and ready to go.
So let's build that answer.
Yeah.
We should probably start at the very beginning, the foundation, the pre-modern era. I always think of this as the dark ages of surgery. Before 1846, surgery was just a desperate last resort, wasn't it?
It was brutal. I mean, truly brutal. As both Morgan and Miller point out, surgery was basically hampered by two massive walls. First, a lack of a sepsis-so infection would kill you if the knife didn't. And second, a total lack of any reliable anesthetic techniques. Speed was the only mercy. Surgeons prided themselves on how fast they could amputate a leg, not because they were showing off, but because every single second was pure agony for the patient.
But they did try things, right?
Yeah.
It wasn't just, here, bite on this stick and good luck. The sources mentioned some surprisingly pharmacological approaches from the ancients.
They were, in some ways, surprisingly advanced. If you look at the Egyptians, for instance, they were using combinations of opium, poppy, and hyoscyamus. Now, just think about the pharmacology there for a second.
Okay.
Opium gives you morphine, an analgesic, and hyoscyamus gives you scopolamine.
Which is essentially a primitive version of a modern premedication. You've got an analgesic and an amnesic, or just a sedative.
Exactly. It's rough, and the dosing was a complete gamble, obviously, but the basic mechanism was sound. Then you had the physical methods. They used compression of nerve trunks to cause nerve ischemia.
Literally just squeezing an arm until when...
Yes, exactly. Or cryoanalgesia, using ice or snow to freeze the tissue.
I was really fascinated by the notes on the Americas. The Aztecs and Mayans seemed to have a completely different pharmacopoeia. The sources mention herbal beverages, which sounds okay, but then they pivot to things like rattlesnake, fangs, and leeches.
It sounds like witchcraft, but there's almost always a biological basis, even if they didn't understand it. But for me, the Incas are the ones that really stand out.
Yeah.
They essentially practiced the earliest form of local anesthesia. They would chew coca leaves, which of course releases cocaine alkaloids, and then apply that saliva directly to operative wounds.
And this was for tree finding, right? Drilling holes in the skull.
Yes. Just imagine having your skull drilled with only a coca leaf poultice for pain relief. But it proves the concept, the idea of a local application, existed centuries before we formalized it.
Okay, so that really sets the stage. Surgery is pain. Then we hit the mid-19th century, and everything just changes. This brings us to what has to be the highest yield section for any exam answer, the pioneers of general anesthesia. This is often framed as the ether controversy.
This is the absolute core of your long answer. If you mess this part up, you lose the bulk of your marks. There are four main players you absolutely have to keep straight: Crawford Long, Horace Wells, William T.G. Morton, and over in Britain, James Young Simpson.
Let's take them chronologically then. Crawford Long, 1842. This feels like a classic case of the first versus the famous, doesn't it?
It is completely. Crawford Long was a country doctor down in Georgia. He noticed that people who inhaled ether at these things called ether frolics.
Basically parties where people got high on ether.
Exactly. He noticed they didn't feel pain when they fell or banged their shins. So in 1842, he used it to remove a tumor from a patient's neck.
So he is technically the first person to use ether for surgical anesthesia.
Technically, yes. But here is his fatal flaw, and it's a lesson for any academic, really. He didn't publish. He sat on the data until 1849. By then, the world had moved on.
So for the exam?
For the exam, if they ask who used it first, the answer is long. But he isn't the father of anesthesia because he kept it to himself. He didn't give the gift to the world.
That brings us to Horace Wells in 1844. I always feel a bit of tragedy reading about Wells. He was so close. He was on the right track with nitrous oxide.
The tragic dentist, absolutely. He saw a demonstration of laughing gas nitrous oxide and had this epiphany that it could stop the pain of dental work. He had one of his own teeth pulled under N2O and it worked perfectly. He thought he'd found the holy grail.
But the jump from the dentist chair to the operating theater, it failed.
Catastrophically. He arranged a public demonstration at Massachusetts General Hospital at Harvard, but he likely didn't use enough gas, or maybe the patient was what we'd call a high responder. The patient cried out during the extraction.
In the audience.
The students jeered him. They called it a humbug. It was a complete humiliation.
And Morgan notes that this actually set anesthesia back a bit, because nitrous oxide was shelved. It was seen as a failure.
Right. It completely cleared the stage for the man who learned from Wells's mistake. William T.G. Morton, 1846. This is the big one.
October 16th, 1846. The ether dome. This is the date absolutely everyone must know.
This is the big bang of modern anesthesia. Morton successfully demonstrated ether anesthesia for a tumor removal on a patient named Gilbert Abbott. The surgeon, John Collins Warren, who was this very respected, very skeptical figure, famously turned to the gallery and said, "Gentlemen, this is no humbug."
Wow.
Now that was the moment. The moment surgery changed from torture to therapy.
But here's a nuance that Wiley's really highlights, and this is a great point to make in a theory paper to show you've read deeply. Morton wasn't exactly a pure-hearted scientist doing this for humanity.
Not at all. He was an opportunist. He added a dye to the ether to color it red and some aromatics to mask the smell. He called this substance lithion.
Lithion. That is a perfect Viva trap.
An absolute trap. If an examiner asks you what is lithion, do not, under any circumstances, say it's a distinct drug. It is just diethyl ether disguised by Morton so he could patent it and sell it.
And that greed is what sparked the whole ether controversy.
Yes. With Charles Jackson and the estate of Horace Wells, who had tragically taken his own life, they were all fighting over the credit and the potential money.
It's amazing that the birth of such a noble specialty was mired in a patent war. So we have Long the first, Wells, the failed N2O demo, Morton, the public success. Then we cross the Atlantic to 1847, and James Young Simpson.
Simpson is the British connection. He introduced chloroform. Ether was great, but it was slow to induce, it caused a lot of secretions, and it smelled terrible. Chloroform was much more potent and sweet-smelling. Simpson used it heavily in obstetrics in Edinburgh.
And there's a huge sociological pivot point here involving Queen Victoria, right? This is more than just a chemical discovery.
A huge point. At the time, there was serious religious opposition to pain relief in labor based on the biblical verse, "In sorrow thou shalt bring forth children."
Right.
But in 1853, John Snow, we'll talk more about him, later administered chloroform to Queen Victoria for the birth of Prince Leopold.
And if the Queen did it. The religious argument just evaporated. It became socially and medically acceptable almost overnight. Miller really emphasizes this as the moment anesthesia became mainstream in society. If the Queen says it's okay, it's okay.
So a quick recap for the student writing this down. Long used it first but didn't publish. Wells failed the N2O demo. Morton succeeded with the ether demo and tried to patent it as lithion. And Simpson legitimized chloroform with the help of the Queen.
That's a perfect summary. If you can lay that out clearly, your pioneer section is done. That gives you the historical backbone for the rest of the story.
Okay, let's move to section 3 then, the development of inhalational anesthetic agents. We started with ether and chloroform, but obviously we don't use those today, so how do we trace this evolution in an exam answer?
You frame it as an evolution of safety. That's the key phrase. Ether was the standard until the 1960s. It was actually very safe from a cardiovascular standpoint. It maintained blood pressure well because it stimulated the sympathetic nervous system.
It was incredibly flammable. A huge problem. You couldn't use surgical cautery in the operating room, or the patient might literally explode.
That is a terrifying thought. And chloroform had its own set of very serious issues.
Chloroform was hepatotoxic. It caused something called delayed chloroform poisoning, where patients would seem fine and then die of acute liver failure days later. Then you had cyclopropane in 1929. It gave a rapid induction. was pleasant to breathe, but again, highly explosive. The whole OR had to have conductive flooring to prevent static sparks.
So the real drive was for something non-flammable and non-toxic. This leads us to the fluorinated revolution.
This is the modern era. It really starts with halothane in 1956. Developed by a chemist named Suckling. It was a complete revelation, sweet-smelling, non-flammable, potent. It revolutionized pediatric anesthesia because you could do a mass induction on a child without them fighting the pungent smell of ether.
But like chloroform before it, it had a liver problem. Halothane hepatitis.
Exactly. It was rare, but often fatal. We now know it was an immune-mediated reaction. That spurred the search for even better ethers. So we got methoxyflurane in 1960, but that was metabolized to fluoride ions, which caused kidney failure, nephrotoxicity.
It really seems like every time they solve one problem, another one just popped up. Then we get to the isomers we'd recognize more readily today, enflurane and isoflurane.
And isoflurane, which was introduced in 1981, really became the gold standard for a very long time. It's a bit pungent, so you can't easily induce with it. The patient will cough and hold their breath, but it is incredibly stable for the heart. It doesn't sensitize the heart to catecholamines like halothane did, which was a major advantage.
And finally, the 90s gave us desflurane and sevoflurane. What is the key concept that Stolting wants us to know about these two?
Blood gas solubility. That is the technical buzzword you need to use. Desflurane and sevoflurane have very low blood gas solubility.
Which means
it means they wash in fast and they wash out fast. You get rapid induction and, crucially, rapid emergence. This is essential for modern ambulatory surgery, where the goal is to have the patient waking up on the table, ready to go to the recovery room.
And we can't leave this section on inhalational agents without defining MAC.
You absolutely cannot. MAC is the minimum alveolar concentration. It was introduced by a brilliant researcher named Ted Eager in 1965. Before MAC, we had no standardized way to compare the potency of these gases mathematically. MA gave us a standard dose-response curve for inhalational agents. You have to mention Eager and MAC in this section. It shows you understand the pharmacology behind the history.
Okay, great. Shifting gears from gases to veins. Section 4. The development of intravenous anesthesia. The origins of this are, well, wild. 1656.
This is one of my favorite stories in Miller. Christopher Wren, yes, the same architect who built St. Paul's Cathedral, and a colleague, Daniel Major. They weren't doctors in the modern sense. They used a goose quill tied to an animal bladder to inject wine and ale into a dog's vein.
The goose quill. So that's the great-great-grandfather of the modern Alvey cannula.
It's primitive, but it proved the concept that you could access the circulation directly. Then, in 1665, a man named Sigismund Elsoltz tried it in humans. But honestly, IV anesthesia was a complete disaster for centuries because we just didn't have the right drugs. Injecting opium or chloral hydrate intravenously was incredibly dangerous.
Until the barbiturate era.
Thiopental, 1934. This is the landmark you need to remember. It was synthesized by Vollweiler and Tabern, but clinically championed by two giants, Ralph Waters and John Lundy at the Mayo Clinic. Thiopental was the gold standard for induction for over 50 years.
Why was it so revolutionary?
It was the first time we could induce sleep smoothly, reliably, and in seconds. It took the terror out of the mask induction for the patient. No more pungent ether being dripped onto your face. Just a small injection, count backward from 10, and you're asleep.
And from there, we moved to the drugs we use every day, ketamine in 1970.
Ketamine is a class of its own. It produces what's called dissociative anesthesia. It doesn't just put you to sleep in the traditional sense. It disconnects the thalamocortical pathways. It's unique because it maintains respiration and blood pressure, making it ideal for trauma patients or in war zones.
And the current king of induction agents, propofol.
The milk of amnesia. Propofol changed everything, especially regarding TIVA total intravenous anesthesia. Thiopental, for all its benefits, made you groggy for hours because it accumulated in fat tissue. Propofol has a very rapid offset, and crucially, it has antiemetic properties. It essentially replaced thiopental in the developed world for routine inductions.
Okay, hold on. We're moving into what the outline calls an exam favorite. Section 5. Pioneers of local and regional anesthesia. Why do examiners love this section so much?
Because it blends anatomy, pharmacology, and helpery absolutely perfectly. And the names are just iconic. If you want to impress an examiner, you need to nail the difference between the pioneers of spinal and epidural anesthesia.
And it all starts with cocaine.
It does. Koller, 1884. He wasn't an anesthetist. He was an ophthalmologist. He was friends with Sigmund Freud, who was studying cocaine's systemic effects. Koller was looking for something to numb the eye for cataract surgery, which was done awake and was excruciatingly painful.
And he found it.
He found that dripping a cocaine solution onto the cornea worked perfectly. This was the birth of topical local anesthesia.
And then in the same year, William Halsted. Now, Halsted is a giant of surgery, but his contribution to anesthesia came at a huge personal cost.
Halsted took Koller's idea a step further. He performed the first nerve blocks, the mandibular nerve, the brachial plexus, also in 1884. He showed you could block a specific nerve trunk and numb a whole region of the body, but as Wiley grimly notes, he experimented on himself and his students.
And became addicted.
Severely addicted to cocaine, which plagued him for the rest of his life. It's a tragic but important reminder of the potency and danger of these drugs we use.
That's a detail that really sticks in the memory. Now let's distinguish very clearly between spinal and epidural, because this is where students often mix up the pioneers.
Right. For spinal anesthesia, the name you must know is August Bier, 1898. He injected cocaine into the subarachnoid space.
And true to the experimental spirit of the time, he didn't just do it on patients first.
No, of course not. He and his assistant did it on each other. And Bier suffered the very first recorded PDPH postdural puncture headache. He described the positional nature of the headache perfectly because he was living it. He had to lie flat for 9 days.
So Bier is spinal, and he's also the Bier block.
Yes, that's another potential point of confusion. He described intravenous regional anesthesia, or IVRA, in 1908. So if you see the name Bier in an exam, you should immediately think spinal anesthesia and the Bier block.
Okay, then who is the epidural guy?
There were actually two. A Spaniard named Fidel Pages first described it in 1921, but his work was somewhat lost to history for a time. The name you really need to associate with popularizing the technique is Achille Dogliotti. In 1931, he described the loss of resistance technique.
The pop.
That tactile pop we all feel with the syringe as the needle enters the epidural space. That's Dogliotti.
And just to round out the local anesthetic section, we have to mention Heinrich Braun.
The chemical tourniquet. A brilliant idea. In the early 1900s, he had the idea to add epinephrine to local anesthetics. He realized it would constrict the blood vessels at the injection site, trapping the drug there and prolonging the duration of the block.
And we still do that today, Lido with epi.
Exactly. It's a fundamental principle.
Okay, moving up the body to the airway, section 6. We take intubation so much for granted now, but it has a rich history. Who are the key figures here?
Well, we have to mention John Snow again. We talked about him with Queen Victoria. Morgan calls him the first scientific anesthetist. He wasn't just guessing. He studied the physiology of ether and chloroform and designed inhalers to deliver a specific, measured concentration. He brought math to the magic.
But for the tubes themselves, the actual hardware.
For that, you have to talk about Sir Ivan Magill. He developed the wide-bore endotracheal tubes we recognize today. Before him, tubes were often narrow and had high resistance. And then you have Arthur Goodell. Goodell is huge. He advocated for cuffed tracheal tubes.
Why was the cuff so important?
Before the cuff, you always had a leak around the tube. You couldn't use positive pressure ventilation effectively, and more importantly, you couldn't protect the lungs from aspiration of vomit or blood.
So it was a massive leap in safety.
A quantum leap. Goodell showed that with a cuff, you could seal the airway completely. He even did this famous, slightly dramatic demo where he anesthetized his dog, who was named Airway, intubated him with a cuff tube, and then submerged the dog in an aquarium. The dog kept breathing through the tube while completely underwater, proving the airway was sealed.
That is certainly memorable. And Goodell also introduced controlled respiration, right?
Yes. Before that, the standard was for patients to breathe spontaneously throughout the surgery. Goodell showed that you could take over the work of breathing safely, which paved the way for complex thoracic surgery.
And a much more recent pioneer, the LMA.
Dr. Archie Brain. In the late 1980s, Miller highlights this as a revolution because it perfectly filled the gap between a simple face mask, which can be hard to hold, and an endotracheal tube, which can be hard to insert. The laryngeal mask airway changed airway management overnight, especially for those cannot intubate, cannot ventilate, nightmare scenarios.
Section 7. Muscle relaxants and balanced anesthesia. This feels like another massive paradigm shift in practice.
It was. The year is 1942. The names are Harold Griffith and Enid Johnson in Montreal. They used Curare, the South American arrow poison, in surgery for the first time.
Why was this so significant? I mean, we had anesthesia before 1942. Surgeons were operating.
They were, but to get a surgeon a relaxed abdomen, what they call soft muscles for abdominal surgery, you had to deepen the ether anesthesia to dangerous toxic levels. Deep ether really depresses the heart and blood pressure.
Ah, I see.
Curare completely decoupled muscle relaxation from the depth of anesthesia. You could have a patient who was only lightly asleep but perfectly relaxed for the surgeon.
Which leads directly to the concept of balanced anesthesia.
Exactly. This is a concept credited to John Lundy again from around 1926. The idea of the triad or quad of anesthesia. Instead of using one massive dose of a single drug like ether, you use a little bit of several drugs. A little Thiopental for induction, some Nitrous Oxide for amnesia, an opioid for analgesia, and now Curare for relaxation.
You balance the drugs to minimize the toxicity of each one.
Precisely. It's the philosophy we still use every single day.
We're cruising through this. Section 8, development of monitoring and safety. How did we get from just a finger on the pulse to the cockpit of monitors we have today?
Well, before electronics, we had Arthur Godel's Stages of Anesthesia. He meticulously described the clinical signs, the eye movements, the pupil size, the breathing patterns that corresponded to different depths of anesthesia, stages 1 through 4. That was how you navigated. You watched the patient, not a screen.
But then technology began to catch up.
The single biggest leap was pulse oximetry in the mid-1980s. Miller states this very clearly. Its adoption drastically reduced mortality from unrecognized hypoxemia. Before the pulse oximeter, you literally had to wait for the patient to turn blue to diagnose hypoxia.
And by then, it's often too late.
Much too late. The pulse oximeter became known as the fifth vital sign. It was a revolution in safety.
And capnography.
Capnography became the absolute standard of care for verifying endotracheal tube placement. The phrase is, no trace, wrong place. It completely eliminated the disaster of unrecognized esophageal intubation. Before capnography, if you put the tube in the esophagus by mistake, you might not know until the patient arrested from lack of oxygen. Now we know in seconds.
And we use the ASA classification for every single patient. Where did that come from?
That was a man named Meyer Sacklad in 1941. He proposed the grading system ASA 1 through 6 to assess a patient's preoperative risk. It's been tweaked over the years, but we still use his fundamental system today to communicate how sick a patient is.
Section 9 touches on critical care and pain medicine. This is really about the expansion of the anesthesiologist's role beyond the operating room.
It really is. It's about the anesthesiologist becoming the perioperative physician. Critical care evolved from simple recovery rooms, which were just places for patients to wake up, into dedicated ICUs with ventilators during the polio epidemics of the 50s.
And anesthetists were the only ones who knew how to manage airways and ventilators.
So they naturally took over the leadership of the ICU. And later we saw the rise of things like the medical emergency team, or MET, to proactively catch deteriorating patients on the wards before they arrest.
And pain medicine also shifted from just give them a shot of morphine when they scream to much more sophisticated systems.
Absolutely. The development of acute pain services, or APS, led by anesthesiologists, and a move from reactive intramuscular shots to proactive systems like patient-controlled analgesia, or PCA, and multimodal techniques.
So, Section 10, anesthesia as a modern specialty. This is about professionalization, right?
Yes. This is about turning it from a practice into a discipline. You have the founding of the World Federation of Societies of Anesthesiologists, the WFSA, in 1956. And the creation of the boards. The American Board was formed in 1937, heavily influenced by John Lundy. This formalized the training and certification. You couldn't just be a dabbler anymore. You had to be a trained specialist.
All right, we've covered a massive amount of ground. For the audio revision aspect of this, let's do a rapid-fire timeline summary. Section 11, I'll call out the date. You hit me with the event and the name. We need to lock these into the listener's memory. Ready?
Let's do it. I'm ready.
1842.
Crawford Long, first use of ether, crucially unpublished.
1844.
Horace Wells, Nitrous Oxide, the failed demonstration.
1846.
W.T.G. Morton, the successful public demonstration of ether, the Big Bang.
1847.
James Young Simpson, Chloroform, and by extension, Queen Victoria.
1884.
A huge year. Two big ones. Koller, using cocaine for topical anesthesia in the eye, and William Halsted, performing the first nerve blocks.
1898.
August Bier, first intentional spinal anesthetic, and the first PDPSH.
1934.
Thiopental is introduced. Lundy and Waters. The barbiturate era begins.
1942.
Curare, Griffith and Johnson. the beginning of muscle relaxation and anesthesia.
1956.
Halothane is released, the start of the modern volatile anesthetic era.
That is a solid framework. If you can memorize those key dates and names, you are already halfway there. Now let's talk traps. Section 12. Common exam questions and Viva traps. Where do students typically lose marks?
Trap number 1 is the question: who discovered anesthesia? It sounds simple, but it's a loaded question.
So how do you answer it safely without annoying the examiner, who might have a favorite candidate?
You have to be diplomatic. Your best bet is to briefly discuss the ether controversy. You mentioned that Crawford Long used it first in 1842, but you must credit W.T.G. Morton with the public demonstration in 1846 that actually gave the gift to the world. That covers all your bases.
Okay. Trap number 2, mixing up the spinal and epidural pioneers.
This happens all the time. Use a mnemonic. Bier for spinal. Just think, drinking beer goes to your head like the spinal headache he got. For epidural, remember Dogliotti? Dogliotti sounds sophisticated and Italian, like the elegant loss of resistance technique he described.
Trap number 3, what is lithion?
Do not get confused. It is just ether. It was Morton's greedy commercial attempt to patent ether by disguising it. It is not a separate drug.
And trap number 4, first 5 anesthetic.
Do not just jump to Thiopental. The very first was Elschultz, way back in 1665, with his primitive goose quill. Thiopental was the first modern, reliable, and useful one in 1934. You must make that distinction between first ever and first clinically successful.
Excellent advice. Now, section 13. Some practical tips for the exam paper itself. How should a student present this information visually to get maximum marks?
Structure is everything. If you just write a huge wall of text, the examiner is going to skim it. I always advise creating a timeline flowchart. It's simple. Draw a vertical line down the page, put the years on the left and the key events and names on the right. It looks fantastic visually and immediately shows you understand the chronology.
And for a long answer question?
Use a table. It's clean and easy to mark. 4 columns. Scientist name, year, contribution, and then the most important one, clinical impact. For example, Morton 1846 public ether demo initiated the modern era of surgical anesthesia. It makes it incredibly easy for the examiner to just tick the boxes and give you full marks.
And if you get a short note on a single person?
Follow a simple 3-part pattern. 1, definition event, who are they and what did they do? 2, historical context, what was happening at the time? And 3, clinical significance today, why do we still care about them? So for Halsted, you'd end with something like, his pioneering work laid the foundation for all modern regional nerve blocks used in surgery today.
We are just about at the end, but let's do one final bullet point recap for the drive home. Top 5, can't miss takeaways.
Okay. 1, 1846 is the key date. Morton and ether, everything pivots around this.
Right.
2, Halsted equals nerve blocks and unfortunately cocaine addiction.
Got it.
3, Bier equals spinal and also the Bier block, IVRA.
All right.
4, Lundy equals balanced anesthesia and the introduction of Thiopental.
And 5.
5, Griffith equals Curare. Muscle relaxation, the game changer.
Perfect. And as we sign off, here's that provocative thought to chew on. We talked about Morton trying to patent lithion to make money and how that caused this big, ugly controversy at the dawn of our specialty.
And it raises a really interesting parallel. If the ether controversy was about patenting and money, how does that look today? We still see battles over proprietary formulations of propofol or new neuromuscular blockers that cost a fortune.
So is the lithion of today just hidden in a different kind of pharmaceutical patent?
It's something to think about, the fundamental tension between medical altruism and commercial gain. It hasn't gone away, it just changes names.
That's a great point. Okay, to our listener, good luck with the Gujarat University exams. Go crush that history paper.
You've got this. Study hard.